This is a 65-year-old lady who's got severe back pain after a previous hemilaminotomy decompression. It's progressive, it's severe, it's disabling, it's associated with neurogenic claudication for short distances. She's become completely dependent and immobile because of her problem. When we look on lateral view, we can see from a central canal standpoint, she's got fairly severe central stenosis with degenerative changes at 4-5 at the disc space with inflammation, at 5S1. She's got a lot of disc space collapse. As we migrate over to the lateral recess, the 4-5 lateral recess is significantly tight at the foraminal segment. This is on the right side. If we do the same thing and go to the extreme left side, she's got critical left foraminal segment stenosis at that level. On axial segments, we can confirm that. This image right here is an axial section of L4-5, shows the facet arthropathy, the broad protuberant disc space. The central canal is small with a big bulging disc there. The left foraminal segment, post-foraminal segment, pre-foraminal segment is critically tight. Right, significantly so, but a little less than left. Our plan is going to be, basically we're going to take this facet off after exposure and after pedicle screw placement. We're going to do an interbody fusion via transforaminal oblique lumbar interbody approach from the left side. We'll have a transverse bone graft in 4-5. We'll have screws in 4, 5, and S1. At L5, S1, we'll use the screws to do a lateral recess decompression. The central canal is generous, so there's really no issue with central stenosis at 5-1. And then we'll use a stem cell allograft for the onlay fusion to follow. And then rod assembly, and that's basically the plan. First of all, when I set up the room, I try to keep all of my room setups identical, regardless of whether it's going to be lumbar, cervical. Because of the amount of materials, the televisions, the fluoroscopy unit, the fluoro table, the microscope, I like to keep the room uniform. It helps the back table staff, and you really can manipulate each intervertebral unit, whether it's cervical or lumbar, very, very consistently, and it helps simplify things, which is all part of the preoperative planning standpoint. At this point, basically, in the planning phase of the case, I consider this, following the review of the x-rays and the identification of the lateral versus central recess stenosis, I consider this the most important phase. Everything subsequent is executing the plan. This is the stage where we make all our final planning. Basically, I use biplanar fluoro to mark the incision, to confirm our location, to get a good orientation of the fluoroscopy unit within the patient, a true lateral, true AP, relative to each vertebra. We like to look at one vertebral body at a time. We'll start out with the top of the wound at L4, being the superior extent of our fusion or our pedicle screws. We'll draw a line in exactly parallel to the pedicle, all the way up to the dorsum of the back. At L4 first, then we'll do the same thing at L5. The approach plane that we need at any given intervertebral unit or any given disc space, the best approach plane is a parallel to the disc space approach plane. By drawing a parallel line to each pedicle, it gives us an exact trajectory to get to the entire dimension of the wound. So with these three lines, 4, 5, and S1, basically that tells us that our wound needs to be right in there. All right, she's a little thick, so it's going to be a slightly deep wound. So we'll make it a little more generous just to manage tissue. You can see her previous incision from her decompression alone. And within that hole, we're going to do an interbody fusion. We're going to approach it from the left side at L4-5 via transforaminal approach. We will start out with pedicle screws percutaneously fluoroscopically placed at 4, 5, and S1 with biplanar fluoro. We will then use the screws as a neuronavigational tool and use a very limited, specific microsurgical retractors rather than a big, heavy-duty muscle injury retractor system. And we'll focus on one interpedicular space at a time. In this case, at 4-5, we'll first do the left side, do the interbody fusion. We'll go from lateral to medial and do that medial decompression. Then we'll go to the right side. We'll go inferior to that pedicle screw, do the foraminotomy lateral first, work our way medially, sparing the dorsal midline. And then we'll do the same thing at 5-1, more so on the left side. Then we'll top load the screws with caps and do the rod assembly, and that's the closing phase of the case. So let's go AP and confirm our pedicular anatomy. All right, now we're gonna go one vertebral body at a time. We want a perfect image of it. Let's angle for L4. Okay, what we want is to get the roof of each pedicle to be parallel to the superior vertebral body line. Now release the C. All right, there you go. Okay, that's a good view of the disc space at 3-4. Let's switch left and right. Okay, and now we'll just make sure we're within the right wound. Okay, there's the left pedicle of L4. There's the right pedicle of L4. Okay, let's now go to L5. All right, that looks pretty good right there. You can see a nice perpendicular shot to the disc space of 4-5. Let me release the C a little bit. So there's a little rotary scoliosis at 4 relative to 5, which we've just confirmed. We'll do this one vertebral body at a time. There's the pedicle of L5. There's the right pedicle of L5. All right, now let's go to S1. The pedicle at the sacral level is much broader than at L5 and L4. So in this case, we can see it right here. I lateralize my sacral screws, so I have very little to work with, and I have a broad sacral amount of bone to work with. So the trajectory is going to be to enter the pedicle here at an oblique plane and dive down. We will do the same thing on the other side, and that makes sacral screws much easier through a smaller hole. In this case, we'll look at left S1 pedicle, right S1 pedicle. So I'm a little off from my lateral marking, but pretty close, so we will move our incision to here. And that'll be our final approach incision.